Okay, so here's our roadmap. We're tackling this using a super structured clinical pathway. We'll hit acute arterial occlusion, chronic arterial occlusion, the all-important ABPI scale, the classic showdown between Buerger's and atherosclerosis, and finally, gangrene and amputation. Part 1, acute arterial occlusion, sudden blockages and the race against time. We're kicking things off with acute occlusion. Picture this, an embolus shoots out from the heart and suddenly jams up a vessel. Bam! Zero time for the body to form any collateral pathways. Typically, that embolus comes straight from the heart, and the big keyword to watch out for, atrial fibrillation, or that classic irregularly irregular heartbeat. When that clot hits, the symptoms are incredibly dramatic and immediate. To spot this absolute emergency, you absolutely have to know your 6Ps. Pain, pallor, which is when the limb turns pale or white, paralysis, paresthesia, poikilothermia, which is just a fancy way of saying the limb gets cold, and pulselessness. But hey, listen up, because here's a huge clinical trap you got to avoid. Pulselessness, that's actually a late sign. Seriously, do not wait for the pulse to disappear to make your call. On the flip side, a complete loss of sensation usually shows up really early on. Catch this within a 6 to 8 hour window, use a duplex scan to pinpoint the block, and you can totally save that limb. But here's the catch, and it's a big one. Rescuing the limb comes with a major string attached. Whether you drag the clot out with a Fogarty balloon or bust it up with thrombolytics like streptokinase, turning the blood flow back on triggers a massive reperfusion injury. Free radicals flood the tissue and the muscles swell up like crazy. But since the fascia wrapping those muscles won't stretch, the pressure skyrockets, causing agonizing pain if you passively stretch the muscle. To prevent this from turning into deadly compartment syndrome, you've got to step in with a prophylactic fasciotomy, literally slicing right down through the deep fascia to let that pressure out. Moving right along to Section 2, chronic arterial occlusion, gradual blockages, and the formation of collaterals. So, with chronic occlusion, we have a gradual thrombus. This slow buildup actually gives the body a fighting chance to build new collateral blood vessels around the roadblock, which totally changes the patient's symptoms. This creates what we call distal runoff. Basically, some blood is still making it past the block, just not enough when the muscles start demanding more during exercise. Because of that restricted flow, patients get intermittent claudication. But your attendings are definitely going to grill you on distinguishing this from other stuff. The vital thing to remember? Vascular claudication is a cramping pain that kicks in only after walking a specific distance, and crucially, it stops when they rest. Now, contrast that with neurogenic claudication from lumbar canal stenosis. That pain is shooting, changes depending on their posture, and feels better when they bend forward. And just to round it out, osteoarthritis pain is totally different from both. It hurts the absolute worst on the very first step they take. As these chronic blockages get worse, the exact location of the pain is essentially a map to the blockage. The pain hits the muscle group immediately downstream from the block. You've got to memorize this classic triad, well, really a quad, for Leriche syndrome, which is an aortoiliac block. The earliest red flag is gluteal claudication, paired with absent femoral pulses, a bruit over the iliac region, and impotence in males. Nail this combination, and you're guaranteed to rack up points on your exams and look like a rock star on the wards. All right, on to Section 3, the ABPI scale, or ankle brachial pressure index. Now we're getting into the data-driven diagnostics. This is a measurement that is absolutely incredibly important for your exams and real-world practice. You literally cannot manage peripheral arterial disease without it. So what is it? The ankle brachial pressure index is basically a ratio. You use a simple duplex Doppler and blood pressure cuffs to get a totally objective look at the patient's arterial health. You take the maximum systolic blood pressure reading down at the ankle and divide it by the maximum systolic reading in the arm. Basically, it tells us exactly how much pressure is bleeding off as the blood tries to travel down the leg. Seriously, take a mental screenshot of this table right now. These exact cutoffs are the difference between knowing if a limb just hurts during a jog or if tissue death is imminent. Normal is 0.9 to 1.3. Dip below 0.9 and boom, intermittent claudication starts. Drop below 0.5, now they've got pain even at rest, usually way worse at night, and they might try hanging their leg off the bed just to get a tiny bit of relief. And if it plummets below 0.3, you are looking at critical limb ischemia. Necrosis is literally knocking at the door. Oh, and quick side note, if you see artificially high numbers above 1.3, think diabetes or kidney disease, because those vessels get stiff and calcified. But here's why this index is about so much more than just saving a leg. For every 0.1 decrease in the ABPI below that 0.9 mark, the risk of cardiac mortality spikes by exactly 10%. That is a staggering number. Peripheral arterial disease is a massive systemic red flag. If the arteries in their legs are that clogged up, you better believe the arteries in their heart are in serious trouble too. Next up, Section 4, Buerger's V's and atherosclerosis, the great debate of chronic blockages. Let's see how all this foundation builds into specific diseases by pitting the two major causes of chronic occlusion head to head. Grasping the difference between these two is the ultimate key to knowing exactly how to treat your patient. So we have to ask ourselves, what fundamentally causes these chronic blockages in the first place, and how do they spread differently through the vascular system? Because honestly, the presentation and the treatment are entirely dictated by which vessels they target and what direction they march. One attacks from the center of the body outward, and the other starts at the fingertips and toes and marches inward. The contrast here is night and day. Buerger's disease, that usually targets younger guys, like in their 30s and 40s, who are heavy smokers. It aggressively attacks small and medium vessels, working from the outside in, distal to proximal, so from the toes moving up. And get this, it doesn't just hit the artery. It takes down the artery, the vein, and the nerve altogether, causing superficial thrombophlebitis. Look at an angiogram and you'll see those classic corkscrew collaterals. Atherosclerosis, on the other hand, is generally a disease of the 50-plus crowd, with multiple risk factors. It strikes those large proximal vessels first and works its way down distally, and it exclusively messes with the artery. Those structural differences, they completely dictate what we can actually do in the OR. Since atherosclerosis attacks large vessels, we've got great options. Angioplasty, stenting, and open bypass grafting are our highly successful first-line treatments. But because Buerger's obliterates those tiny distal vessels, there's literally nothing to bypass to. It's physically impossible. So instead, for Buerger's, we do a lumbar sympathectomy. This forces cutaneous vasodilation, essentially stealing blood from the muscles and shunting it to the dying skin. And that right there is exactly why this procedure is strictly contraindicated if the patient only has claudication. If you steal blood from a working muscle to feed the skin, you're going to instantly trigger rest pain. We only pull this maneuver when the muscle is already unsalvageable and the skin is actively dying. Now, back to our atherosclerosis patients. When the balloon angioplasty and stenting eventually fail, you've got to know your bypass graft materials inside and out. If the blockage is high up, like iridoferomoral, above the inguinal ligament, your go-to material is Dacron. But if you're bypassing below the inguinal ligament, say a femoral-popliteal graft, the absolute gold standard is the reverse saphenous vein. We flip it inside out so the natural venous valves don't block the arterial flow. If you absolutely have to use a synthetic graft below the groin, PTFE is your best bet, though to be fair, it's still second best to the patient's own vein. Finally, we arrive at Section 5, gangrene and amputation, when intervention is simply too late. This is the grim end-stage reality when, despite all the stents, the balloons, and the fancy bypasses, blood flow just cannot be restored. The tissue undergoes both microscopic and macroscopic death. Out on the wards, you'll encounter two main types of gangrene. Dry gangrene is desiccated. It's shriveled up, gradual, and it forms this very clear, hyper-aesthetic line of demarcation between the dead tissue and the living tissue. Wet gangrene is a whole different beast. It's oozing, caused by a superadded infection or venous block, the boundary is super blurry, and it actively creeps up the limb. Now here is a classic trick question they love to throw at you on rounds. Can dry gangrene turn into wet gangrene? The answer is absolutely 100% yes if an infection manages to get in there. Also, keep in mind that with dry gangrene, because bone has a much better blood supply than skin, the bone's actual line of demarcation will sit further down the limb than what you see on the skin. When we reach that point, we have to make the tough call to amputate. I absolutely love this old-school medical mnemonic for amputation indications. Dead, deadly, and damn nuisance. Dead is your straight-up gangrene. Deadly means there's a life-threatening spreading gas gangrene or sarcoma in play. And damn nuisance? That refers to severe, painful contractures, fistulas, or massive deformities that turn the limb into a painful burden rather than something the patient can actually use. So when we head into the OR for an amputation, our entire philosophy shifts to maximizing that patient's future mobility. For digits, we go with a ray excision or transmetatarsal amputation. For the leg, you do everything in your power to save that knee joint. A below-knee amputation is vastly preferred over an above-knee one, simply because keeping the knee offers the best possible shot at walking again. We shoot for an 8 to 12 centimeter stump and typically use a long posterior skin flap, wrapping the thicker skin from the back of the calf right around to the front. That cushion ensures the patient can still live a highly functional life with modern blade prosthetics. To wrap up this explainer, I want to leave you with a pretty stark, provocative reality from the wards. We talked about Buerger's disease, right? The absolute only way to stop Buerger's is to stop smoking. But that addiction is incredibly profound. There are documented cases of patients losing toes on one leg, then the other, then fingers on one hand, then the next, until they literally have to ask hospital attendants to place a cigarette in their mouth because they don't have any fingers left to hold it. It leaves us facing this intense question: how do we ethically manage a surgical disease where the patient absolutely cannot stop the root cause? Sometimes the hardest part of vascular surgery isn't the physical bypass at all. It's navigating the psychological grip of the underlying risk factors. Because really, how do we treat the vessel when we cannot treat the mind? Something to think about. Thanks for joining me on this explainer. Keep pushing forward, and I'll catch you next time.